It's a pleasure to be here. Why? Because we will talk during 1 hour about robotic in PCI. And what I say yesterday, and remember that we start EuroPCR. The first case in the main arena, the first live case was on robotic. And just to really give the message that we believe, and I personally believe, the major impact of robotic in our daily practice in the next coming years. So today we have a real pleasure to have this symposium organized by with the support of RoboCat company, and a pleasure to have to share this session with Michael Haude, will be the moderator of the session, Martine Gillard, and Stéphane Verey. So the chat master will be Rémi Sabatier and Eric Durand. So the objectives are I have no conflict of interest, sorry, not so right. These are the objectives of robotic PCR. Just this slide to show you the importance of the robotic and place the history of robotics in the beginning of PCI. So today the objective is to understand what is robotic PCI from a recorded case from the cath lab of Martine Gillard, to learn more about the benefit and recent clinical results that we get, and to envision together the potential future of robotic PCI. So it's a natural continuous evolution. Since the beginning of surgery, we were moved to the minimal invasive procedure, and today we have the robotic PCI. And what's important to see, it's the revolution that the robotic represent for all the people working in the cath lab. In other words, we moved from the manual navigation and manually positioning of the device to the positioning via joystick, robotic precision in this positioning. The second point for all of us, we are working from particularly Michael and myself and me since more than 30 years or close to 40 years in the cath lab, under X-ray exposure. It's a massive irradiation that we can get. And it's true that even if we are together in good health, if we can protect from radiation all the next generation of interventional cardiology and all the people, nurse and IL professional working in the cath lab, this will be a major advantage. So interest of robotic will be to provide to all the team working in the cath lab a full radio protection. Other point, when we are working during years, daily practice, since years and years, with leather protection, we know that there are, particularly for the interventional cardiologist, orthopedic injuries. And this could be a major problem for the whole generation. And it's true that if we can work sitting in front of you console of the robot, this will be a major difference some decades later. And finally, we will try to move from the complex and heterogeneous learning and training to a simplified learning. In other words, this teaching, learning, and training experience will be really really improved by the role of the technology. So a lot of advantage for this robotic PCI. So I'll leave now the microphone to Martin.
Yeah, while Martin is going to step up to the microphone, it's my real pleasure to invite you here in the audience to send us in here our questions or your questions. Use the app, please. You have the opportunity. And during the two discussion sections that we're going to have throughout this session here, we try to answer as many questions as possible. Martin, please.
So thank you, Michael, and thank you for this invitation. So I have no conflict of interest. So I will show you the setup of the room. And yeah, it is the patient with the robotic unit and the arm of the robot. And also what is important is the control room. In the control room, you have the physician who are positioning and seated, comfortably seated. And he is protected. You can see there is no scrub, no lead apron, and so on. So it's very easy to work with the joysticks. And but you can also put the control system inside the room, but protected by lead apron. And also it would be inside, completely inside the control room. So you have to know that it's compatible with the femoral or radial access from the left or from the right, because the robot is moving, and it can be adapted the eye and the position according to the function. It's also compatible with all market-leading guide wires, balloon, and stands. It's not actually compatible for the imaging, probe of imaging like OCT or IVUS, but it will be for the next generation. And if you have some problem during the procedure, you can very quickly disadapt the robot and do it manually. So it's very, very in a kind atmosphere. So, as Jean said, it's a drastic reduction of irradiation, because, as you see, the physician is in the room, in the control room. There is no beside the bed, and his seat position, close visualization. You have a very high concentration. You can see only the screen, and you can adapt your movement with the joystick. So it's very, very easy to do it. And also there is a precision of the robotic. And you can advance millimeter by millimeter your wire. You can turn it, you can rotate, you can advance, you can rotate. So it's very, very easy. And also you can positioning the balloon or the stand very with a millimeter precision. So another advantage, when you have two wires, for example, or only one wire and a balloon, the wire doesn't move because it is fixed. So it's also an advantage when you use this kind of system. So what about the radiation? The principal operator do not receive any radiation because it is in the control room, but for the nurse or for the fellow who are on the bedside and we perform balloon inflation or injection of contrast media, there is a very low, as you can see, irradiation of this of the fellow or of the nurses. So thank you very much for your attention.
Thank you.
So now I can show you the recorded case.
Yep.
So it was 84-year-old man. I performed it last week. And he has aortic stenosis, severe aortic stenosis. He's symptomatic. So we decided to, as is normal, to make the assessment of the coronary before treated by TAVI according to the decision of the R team. So here it is the left coronary artery. You can see that there is a lot of disease in the circumflex, but as I mentioned, I go perhaps too quickly, there is akinesia of the inferior lateral wall, so we decided not to treat this circumflex. Then we analyze, you can see that there is some calcification on the LAD and a very diffuse coronary artery disease on the circumflex artery. Then we move to this position, and we can see here a lot of stenosis, 3 stenoses on the LAD. And the right coronary artery disease, there is also artery disease on this part, but we decided, all our team decided to treat only the LAD of the LAD. So normally there is a sound, but so we have not. So here we make sterile drapes on the robot. So we adapt the robot at the eye. We perform a left radial puncture. So we adapt now. We fix the guiding catheter in the robot. We open the single-use cassette, and we insert the guide wire inside the guiding, as you can see, as usual. Here it is not a nurse; it's a young fellow. So we, after insertion of the wire, we fix the guide wire inside the linear wheels, and with these wheels, they can move all the system inside the guiding. Now we close the single-use cassette, and now, as you can see, Professor Eric Durand is comfortably seated in the control room. He advances the guide wire, and with this 2 joystick, here he advances it, then he retracts it like that, and then he can move, make the rotation of the guide wire according to the difficulty to advance in the LAD. Unfortunately, in this case, we use a BW, but it was not enough, so we decided to change and to use a whisper, and you can see that the BMW is fixed, and now we advance the whisper with the joystick, the left one, and you can see it's in real time. For the BMW it was difficult, but for the whisper you advance very easily. So we perform a contrast media injection on the bedside, so it's the fellow who perform it. So now you see but he wants to go to the collateral, so with the joystick, it's very easy to advance. So now the wire is in position, and we decide to implant the balloon. So we choose a balloon about 15 millimeter and 2.5 diameter. So he inserts the balloon. So he takes care because he doesn't want to have to make some, but we can do it quicker than that. But this fellow is a very nice fellow, and he takes time, I think. So now he moves the balloon inside the catheter. He fixes the guide wire in the linear wheels. And there is also here another wheels in order to fix the balloon or the stand. And by this way, we can move wire and also a balloon or the stand with the 2 joysticks. So now it's fixed. It locked. So you see it's very easy. It's not a complicated cassette. So now with the other joystick, the left one, he advances the balloon at the position, and by this way it's very easy to advance at the millimeter by millimeter, and you can choose exactly the right position before you make the inflation. So the wire is fixed, so it doesn't move when you move the balloon, and So now the fellow is protected and inflates the balloon, as you can see. So we use 12 atmosphere at this time, and then we go to 18 atmosphere, but there is still something. So we decided to change the balloon and to use a non-compliant balloon, a small one, because as you can see at the beginning of during the coronary angiography, you see some calcification on the proximal part of the LAD. So we decided to do a non-compliant balloon. So here it is the first one. So here it is a non-compliant balloon. So you can see that Professor Eric Durand is moving with the joysticks. So now we go with the non-compliant balloon. It was 8 millimeter and 25 millimeter diameter. And then after the contrast injection that will be performed by the fellow, we advance the stance. It's a long stance. It's 30 millimeter long and 2.5 millimeter diameter. So we can advance the stance according to the position that we want to do and advance millimeter by millimeter. So you can see it's very easy, even if the artery, there is a calcification of the artery. So now we inflate the balloon. So I think there is more time than when you do it manually, but the comfort is more important and the precision is very good. So now we deflate the balloon, we perform the stand-Vs, and because we like QFR, we decided to perform a QFR in less than 1 minute in order to see if the result is good. You know, it's the new version of the QFR. It's very easy to do it, and the result is satisfactory. So we decided to end the procedure at this time. So thank you very much for your attention.
Thank you, Martine. I think we have plenty of minutes to discuss. We have seen now how the setup is. We have seen how you did the procedure. We got some questions. Let's start up with this setup. The operator with the operating terminal is moving out of the direct cath lab. Is it important that he still has visual contact in the lab to see the patient, to see the nurse? Is it necessary otherwise to have a camera to watch that? Or can he just be anywhere and perform it without that kind of visual contact which we are used to have with our patient?
I think it's important to have always a look to the patient and also to what happens in the lab. So you can be in the control room, but it's good to have a camera in order to have a vision of what happens in the cath lab. For myself, I don't know.
No, it's exactly the same answer. What we have in our lab is to have a camera on the patient. And the patient has also close to him a microphone. So if he wants to say something, we can hear him immediately.
So you have the opportunity to perform the contrast injections also from outside. Can you tell us how you manage that? Stefan, you're also using the system?
Sure. Yeah, well, that's feasible. I mean, it's both ways are possible. You can actually have a fellow or a nurse standing next to the table and inject, but you'd also have a remote injector, so to be able to inject the dye that you actually want to inject. So you can do it remotely.
It's true that we can do the control injection totally remote. That's what we have in our setup. We have the cassette in the control room. We have the console, and we have the possibility with a pump to inject contrast from the control room. The only point that we cannot do is the balloon inflation. That's we cannot have. This is not working with 2 meters of. That's the only point. So we need for the balloon inflation somebody close to the table, but fully protected, as we saw in the video.
There is hope at the horizon. There will be a web-based kind of inflator which you can start from all over in the world if you like. So it's a reasonable next step. I mean,
Sure.
Yeah. For those of you, and I've first asked Martine because she showed us the case. When you start doing these kind of procedures, what is the learning curve? I mean, we are all more or less in the same generation. I call that the generation joystick. So we had a time when we loved to work with joysticks. I don't know whether you made this tennis game on your TV screen with a joystick. So what is that feeling now? Returning to that level and getting off your tactile feedback on your fingertips on the wire.
So after the first using of the robot, I said, okay, I lose my sensation of the finger, but I have no sensation of the finger. When I move a wire, I saw that the wire don't go in the right direction or have a problem because the wire is kinking of the wire. But we have not a lot of sensation. So I think the best sensation is the eye. And with the robot, as you are very close to the monitor, I think the eye is more accurate than when you perform in a room. So I think it's very no change for me.
Yeah. Several questions came in how far you already can push the borders of this technology. Can you do bifurcations with that? Can you do complex left mains with that? Can you do CTOs with that? Jean, maybe you can start and take one of these suggestions and give us an answer.
Yeah, technically we can do bifurcation. We have done bifurcation. We have done left main, few CTO because I don't like to do CTO. I treat simply with beta blocker, but left main bifurcation, all these kind of thing, you can do it. The point is that at present time, but I know that the things will change in some months. But at present time, when we want to work with 2 wires, place the wire, the principal wire in the distal major vessel, for example, AD diagonal, a wire in the vessel, you are working on the wire. The wire in the side branch, in the diagonal branch, we could place to protect the side branch and park the wire on the side, and you block it. And then you move, you work on the LED wire, placing the stand, etc. And then when you have to, for example, perform a kissing balloon, we have to remove the wire, park the other one, and place the diagonal wire again through the struts of the stand, advance the balloon. During this time, the LED wire is parked, etc. And we can work like that, side by side. But of course, what we need, it's the double channel. In other words, have the possibility with the joystick to advance one wire number 1, and then you move wire number 2, and to play with the 2 wire at the same time. So at present time, this is not available on the market. Whatever the company is exactly the same for your concurrent. It's exactly the same. We are working with a single wire, but this is of course in the vision of the RoboCat company. I can say that. It's not, but everybody will wait for the double wire technique, and this will come in the several months. And this, of course, will change all the procedures. It will be really more simple.
I just wanted to make another comment regarding the previous point Michael was referring to as us being the joystick generation, but I think I would call ourselves the control freak generation, and we have been in control of everything what we have been doing so far. And at first, when you do robotic PCI, you think, well, I'm out of control here. I don't have it anymore in my hands. You don't have the tactile feeling. But it's just a mindset. I think if you give it a few shots, like 2 or 3 cases, then you're very familiar, rapidly familiar with having this visual feeling rather than tactile feeling. And I think once you have made that mindset, then I think it's a very different approach, and you feel very safe in what you're doing. So that's my only comment to that.
I think one question that was coming up here as well, I think it's an important one. How is that taken from the patient side? If the physician is no longer standing next to him rather than a nurse, nothing against the nurse and the NAP. I mean, they get the Etika Award this year. They are our big team partners, but in former times, and a lot of our patients already had procedures, they knew that their operator was standing next to them. What is the response, John, you get from these kind of patients?
The response, there is a few points. The number one, when we explain to a patient that we will perform the PCI using the robot, it's a magic word, you know, so immediately the patient is smiling, you see this in the eyes. And so there is no problem to convince a patient to use a robot. The second, the role of our role, and the role particularly of the nurse, it's to explain what will be his situation for the patient when we will be on the table during the procedure and when we will use a robot. So the nurse explain all the steps before to the patient. So they have a major role. And second, the nurse can have a microphone, and during the procedure, she can communicate with the patient.
Just in that line, if you allow me, because the question popped up here, do you need a dedicated informed consent from the patient that he will be treated with the robot? Do you inform him before, or do you just make the clinical indicated informed consent?
We use only the classical informed consent. No, we have not a specific one, but perhaps we have to think about that.
Yeah, same in Toulouse, but maybe the things will change in the next month.
Yeah. Okay, I think if we follow our timeline, Jean, maybe we need to proceed, and you're going to invite Stefan for his presentation.
I think we can move, to the second lecture, and I have great pleasure to invite Stefan Beray, and we talk about the clinical study result, what we can obtain today with R1.
Thank you very much, Jean, and I'd like to thank RoboCat for organizing this symposium and giving me the opportunity to share on behalf of all colleagues and investigators to share these results of the R-Evolution European multi-center study. So let's focus a little bit on the study design, and again, at this point in time, I would like to acknowledge and thank the co-investigators for the work that has been done. It is a prospective multi-center single-arm registry, basically. It includes 62 patients targeting 64 lesions. And this was done at 6 sites. And you can see them. It's in the Netherlands, in Belgium, in Luxembourg, and in France. The indication were de novo lesions, up to 2 in a single procedure, so 1 lesion per vessel. And the exclusion criteria, as you can see, here are length of more than 38, diameter of more than 4 millimeters, severe calcification, tortuosity, bifurcation, osteal lesions. So the classical stuff for first in men. And the follow-up was 1 month. The primary endpoints are clinical success, that's defined by absence of major complication at 30 days follow-up, and the device technical success as defined by the robotic PCI without total manual conversion. There's a number of secondary endpoints which are also very important, which is the procedure duration, defined by time difference between sheath placement and removal of the sheath, and robot duration, so the true robotic navigation, and then the guide wire removal. Obviously, we were also looking at the exposure of the X-rays for the operator and looking at the amount of contrast. I'd like to stress that this study was performed in the midst of COVID, so there were some delays in recruiting Nonetheless, everyone did a big effort to enroll and finish the study. These are the baseline clinical characteristics. Overall, the mean age was 65, so rather young population of patients, and majority were male, 80%, more or less. I'm not going to talk about risk factors and medical history. That's a classic clinical presentation. I think it's important to mention that there are patients with that are unstable and have non-STEMI, which is around 20 to 22%. If you look at the angiographic characteristics here, as Martina already pointed out, radial access 97%, which is a good number. And if you look regarding the distribution of the arteries, it is a homogeneous distribution. We were enrolling LAD, CIRC, and RCA. There are also, the majority was, the plan was actually to go for rather simple lesions, but nonetheless, there were 25% of complex lesions that were enrolled in the trial. Pre-dilatation was performed at around 60%, and there's about 1.05 stent per lesion used. And then again, almost 40% received a post-dil. So operators did a good job in really taking good care of the lesion. And so here's the clinical and technical success. At hospital discharge, there was 100%, and at 1 month, there were no MACE, so again, 100% clinical success rate. If you look at technical success, that goes up to 95% roughly. There was manual conversion. There was, first of all, the inability to cross the lesion with the balloon due to a lack of support. A software error in the second case due to a wrong adjustment of the guide wire into the pads of the robot. And then there was a non-occlusive coronary dissection, which was unrelated to the robot. So 2 out of 3 manual conversions were not related to the robot. And these are also important numbers here. If you look at the procedural duration, and I provided you the definitions of the procedure duration and the total duration and the robotic duration, you can see that in some cases it was only like 8 minutes time, and then others did a little bit longer. But overall, it was 17.5 minutes for the robotic and 37.5 minutes for the procedural total duration. In terms of contrast volume, again, the total volume was a little higher than the robotic volume, so it means that while you're doing the case and you know what you're targeting, you basically don't need that much of contrast. And I think that was also discussed during the opening of PCR earlier this week on Tuesday in the main arena, where also the same question came up regards the contrast use in robotics. How about the radiation exposure? Well, we have to look here, what are we measuring? We're measuring the theoretical exposure and the operator exposure. And there were some differences in sites. In 2 centers, for instance, there was 2 operators were non-sterile, so the dose received during the guiding catheter insertion and positioning was added to the robotic operator dose just to make sure that everybody is treated the same way. And those measurements were performed on the lead apron and underneath the lead apron. When you look at the numbers that are under the lead apron, you actually come up with a significant reduction of around 85% under the lead apron, so the theoretical versus the robotic. And if you look at the on lead apron, you achieving a reduction of roughly 77%, which is really significant. So the take-home messages that I want to give away here today is actually, first of all, there's 100% clinical success rate with 0 MACE at day 0 and at day 30. There is 95% and more technical success. There's a roughly 85% average reduction in physician radiation exposure, and technical success has been achieved across the board in experienced centers. So to provide you with some more data here, there's an ongoing China pivotal study, also looking at safety and feasibility of the robotic PCI with R1. The design is very similar to what I just explained to you. It's done at 4 centers in China. The goal is to enroll about 150 patients. And I think already they're very close to finishing the trial. It's expected to finish actually by the end of this month. Looking at the same clinical endpoints, absence of major complication in terms of clinical success, and in terms of robotic PCI without total manual conversion as device technical success. And the secondary endpoints are similar. So that's one important trial. And then there's also, as a follow-up, the change registry that is to be open for all robotic centers involved. Evaluate the R1 in daily practice use. And again, it's a prospective multi-center single arm where up to 500 patients will be enrolled at 15 centers. Exclusion criteria this time will only be STEMI and cardiogenic shock. And again, we will be looking at clinical and technical success as defined here. And there's going to be a number of secondary endpoints, as we already have discussed. So with that, I would like to end, and thank you for your attention.
Stefan, thank you. Thank you very much. We received quite a large number of additional questions, and I will take them as they were coming in. Maybe, Martin, you can start, because you showed us how you started your program. Which are the right patients and right lesions to start with when you want to do your first robotic case?
Yes, I think we need to have a lesion with not a lot of curve before, because it will be more difficult. An artery with not too much calcification, so no calcification, no curve, not very high curve, but by the other way we can treat all the lesion. I think it's a very important point, because with this robotic system, we have we cannot positioning the guiding. So if there is too much curve or if there is too much calcification, as you know, the guiding will remove. So we have to replace it. So if we have not this kind of lesion, we can do everything.
Thank you, Martin. Joe, in the same direction. The system doesn't allow us to steer the guide. So we need to have a good guide support in there in order to perform the procedure. Can the system handle a guide extension? Because it's also on the wire distally. Can it advance a guide extension?
I don't know, because I didn't try that. I didn't try that to advance a guide extension via the guiding catheter. We have to try.
You have a comment on that?
Yes, I'm from Madrid, Spain. We also are doing robotics, and we have used a guideliner, a guide extension, in about 6 cases to have extra support, mainly in curved circumflex or calcified RCA, and it can be used as a device. It works.
Okay, thank you for the precision, because honestly, I didn't try that.
Yeah. Now we start all the questions concerning the tools that we regularly have on our shelves, whether we can also use them in the robotic setting. One colleague said the 20 megahertz IVUS catheter. Can we use it? So not the sheeted one?
Normal.
The regular stiff shaft IVUS, the very old one, for those who still have it.
I think we don't use it because we think that it will be difficult to have the rotation due to the wheels who close the system. So for the IVUS, the rotation is very, very important. So we need to have, for me, it's not possible actually, but in the future it will be possible. I hope so.
I can tell you it works because we did it in our first case in Germany. It's a quite stiff catheter. There's no rotation. It's the old one, so it works pretty well.
Yeah.
And the interesting thing is you can use the robot to make a nice pullback, a very standardized pullback. You don't have to have these big motors. It easily works. All other tools. What do we have here? IVL of much interest. Can we advance an IVL catheter via the robot?
I haven't done it, but I assume you can.
Yeah. I even did with you. I think you can because the shaft is not different from any other balloon.
Exactly.
Yeah. Cutting balloon. Cutting balloon also. There's a lot of interest in cutting balloons. Can we advance the cutting balloon? I think so.
Yeah.
I don't see a reason as to not
No.
to use it.
Yeah. And now we escalate the question. When you need to have a guide extension, so let's call it a guideliner, in order to stabilize your support, can we work then through the guideliner with the system?
Yeah, for me, why
Okay.
not?
So you see there's a lot of possibilities to continue work like you used to work. Some things don't work. Some questions were coming up to the wires. Can you use hydrophilic wires? I mean, they are once they are wet, they are very slippery.
Yes, in my case, we use one. We use a Whisper, which is an hydrophilic wire, so it's no problem at all.
Okay. And then, for those of you who have experience with the device, Stefan mentioned it, this kind of working with the joysticks rather than having this tactile feedback. I think we all have our way how we configure the distal tip of the wire. There are the benders and there are the kinkers. Now, going back to this device now, just having the joystick, did you change your way how you prepare your wire? And when you are not able to can use the wire as you like to, do you then ask your nurse to reconfigure it because you are outside non-sterile? How do you perform that? Sure.
So technically, I place exactly the same shape according to the anatomy of the vessel, the anatomy of the lesion, coming from the baseline angiography. So no change from the bending. And when this bend is not working, what we have to do is to remove, reshape, and re-engage or changing the wire. But there is no difference to the manual compared to the manual feeding.
Yeah, I agree. I mean, in terms of operations, there's really no magic to it. It's basically the same procedure as usual. It's just the robotic PCI approach is a big facilitator of what we're doing.
Final question that came up is, once you could encounter a complication, a severe complication, let's consider a perforation, how quickly can you convert back to a manual procedure?
Or it's very, very easy. It takes less than 1 second or 2 seconds to take the system out of the cassette and use it manually as usual.
Okay, thank you. So, Jean, why don't you take the last minute of that symposium to wrap it up?
Yeah, we can do that. To be a pleasure. But before I would try to say, not to convince you, but really to tell you that the problem, because it's always the same question concerning, we lose the tactile, the feeling of with the fingers on the wire. And it's true the first time, when you have the joystick and not the feeling of the wire, it's a little bit surprising. But I can tell you, after 4 or 5 cases, you feel something differently. In other words, it's the connection between your hand, your fingers on the joystick, and what you see on the screen. And what Martin tell you, we are working very close to the console. So it's a totally different view of your wire, of your coronary system, your coronary anatomy. And immediately when you advance the wire and you could detect that the tip of your wire is a little bit bending, immediately you go 1 millimeter back or 2 millimeter back, you change from the left to the right or the right to the left, and you advance by millimeter. So it's totally different with what we are doing manually with the talker and try to do that following what you have. It just pull back 1 or 2 millimeter, turn, advance 1 or 2 millimeter, and you find the right way to advance the wire to the distality. So it takes, what I would say, 4 or 5 cases, and immediately you have this automatism created from what you see and what you are doing with the hands. It's really curious. And again, I tell you, I'm not the young from the young generation, 30-year-olds, manipulating the stick. I never did this before. I am close 70 years old, and we can do it. Absolutely. There is absolutely no difference. It's very easy to manipulate, yeah. So, the last word. So, what are the, of course, when you talk about robotic, there are some advantages, some inconvenience. What I will say, the advantage for the patient. For the patient, it's and the safety of the patient is the extreme precision in the navigation of the wire, in the stent selection navigation, the stent positioning. It's really millimeter by millimeter. And again, this is doing by an operator with absolutely no fatigue. You are sitting in front at your console, in front of your screen. You can have a cup of coffee on the right, and you manipulate millimeter by millimeter. It's totally different environment, and this is really the major difference when we are standing up, normally, usually, during hours, patient after patient, close to the table, and we are sitting like sometimes the radiographers, sitting in front of the image of the scan, CT scan of that. It's exactly, absolutely no fatigue. And this is a major, major advantage. For the cath lab team and the operator, nurse, NAP, and technicians, it's a dramatic reduction of the radiation exposure. This is really impressive. And certainly, but we will see in the future, a reduction of the orthopedic problems. So what we could say in conclusion is that this is feasible. The first experience we have, it's feasible. We get good results. We treat, you saw from Stéphane at the beginning, a simple lesion, but with experience we moved very quickly to B2 and C lesion. Certainly, this is we are the first generation of a robotic experience. We need some improvement for in the future to treat more complex lesion, particularly the double, I don't know the name, double channel, double tube, but we need this possibility to move at the same time, 2 wires, 2 balloons, and this really will be a major, major improvement. And of course, the possibility to use all the intracoronary imaging device. So the cath lab of the future, I didn't do this drawing, it's not from me, but we can really think that in the next decade, this will be in the position of interventional cardiologist sitting in front of a big screen and, moving from with a unique interface, integrating all the system, all the equipment available in the cath lab. We could have augmented 3D live image on your wall. You could manage from one console different cath lab. That's a possibility on site, and maybe online an operator could be connected with a different cath lab in the different hospital. This is a possibility. What will be fantastic will be the improvement of the quality of imaging. What we will see in the next year will be certainly exceptional compared to what we have today, and the automatization of all the technique, and of course integrating of machine learning to get recommendation, etc., etc. In other words, you have at your console, you have this kind of lesion, and you click it immediately. You will have the possibility to have the recommendation of some people telling, in this particular case, you could do this, take this advice here at your console. So it's a dream, but really to see this automatization in the future, what I will say, I would like to be 30 years younger in order to have the possibility to see this in the next decade. For the young generation, it will be really impactful in their day-to-day practice. Thank you. I hope you have enjoyed. And thanks to RoboCat company, and hope that we could collaborate in the future on this improvement in the robotic PCI. Thank you.